right. So we have a special guest today, a guest lecturer, Dr. Mingo, who is from Georgia State and is an expert in older adult healthcare, specifically arthritis. Did I read that?
So you did. I started out with arthritis, and I have since transitioned to more MCC, so multiple chronic conditions. So now I focus on multiple chronic conditions in older adults.
Okay, that's a wonderful topic to get into, because I think occupational therapy as a profession is really trying to emphasize the multiple chronic conditions and in primary care and stuff like that. So that's sort of like an emerging area, I believe. So that's great. So again, I'm happy that you're here, and I thank you so much for helping us out by giving the lecture.
All right. Well, first I just want to thank you all for inviting me today. This is an exciting opportunity. So as stated, my name is Chivon Mingo. I am an associate professor in the Gerontology Institute at Georgia State University. And it's definitely with great honor to be invited for your November meeting to speak. And one of the things that I found most exciting in preparing for today's talk was just essentially the alignment of the mission of occupational therapists and my mission and drive behind my research agenda. So to tell you a little bit about myself, I am a trained gerontologist, and people often wonder, what does that mean or what is that? I actually have done all of my studying and background work in gerontology. My PH.D. is in gerontology from the School of Aging Studies at University of South Florida, and I since went on from there. I did some work for 2 years at the Thurston Arthritis Research Center and the Institute on Aging at University of North Carolina at Chapel Hill as a postdoc. And then I joined the faculty at Georgia State, where I am in the Gerontology Institute. And as a part of this, my work has focused on mitigating health and healthcare disparities. So really looking at the health of aging racial ethnic minorities, and looking at mitigating those health disparities through the design, the development, the evaluation of behavioral interventions. And so it's interesting because a lot of the work that I have just followed in my own studies have included occupational therapy as a component of behavioral interventions, particularly community-based interventions. I tend to focus my work on community-dwelling older adults, and we'll talk a little bit about why and my focus and my interest behind that. But the work that I do, I'm very confident that it is applicable and transferable to older adults who may be living in a community setting, in an institutionalized community setting, or at home in the greater community. And so I think that the importance of what I will talk about today is not only bringing a gerontological lens to today's talk, but also the diversity piece that I think in many cases is oftentimes either overlooked or understudied. And so I like to think about how that diversity and gerontological lens influences the type of health and health care that we provide to aging individuals across the lifespan. So what I hope to do today is almost take you on a journey to talk about my work in chronic disease self-management among racial and ethnic minority populations, to start off by talking about population growth and the current demographics, go into a little bit about chronic diseases and chronic disease management among older adults, and then really bring it home talking about the importance of diversity in aging, where we can't talk about this without addressing health disparities and thinking about the health inequities that continually to plague these specific subpopulations, and just brainstorm collectively. I would love to hear from you about how we can come together and think about using an interdisciplinary perspective to achieving health equity in an aging society. So again, I believe this talk is timely considering the challenges that we face in today's society when it comes to everyone having the chance to reach their full health potential, regardless of social, economic, demographic, or geographic circumstances. I think Dr. Martin Luther King Jr. said it best when he said, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. So I feel like that being in good health contributes to one's ability to survive and thrive where we live, where we work, and where we play. And we say that oftentimes, and people are like, what do you mean by where we play? Where we socialize, where we communicate, where we engage. Being in good health makes the ability to continue in that realm possible. In my opinion, being in great health is one of life's greatest blessings. And so anytime that we can talk about how to promote health, how to prevent chronic diseases, or how to help individuals successfully manage chronic conditions once they have been diagnosed, to me is imperative and a discussion that needs to be continued within the area of gerontology and the area of health and healthcare as a whole. So many of you indicated that you have some experience working with older adults, so I know many of these numbers will not surprise you in any way, but in true gerontology fashion, I feel like we cannot start a talk without sharing why we know our work is so important and how we understand the importance of it to those who may be outside of our discipline. So over the 20th century, there was a significant increase in the aging population. So what we have seen from about 1900 to the end of the century is that the older adult population has increased from about 3.1 million of those aged 65 and older to 35 million. This population shift has continued in the U.S. with the baby boomers entering into this population starting back in 2011. So we know that in 2011, the baby boomers started coming into 65 plus, and that we'll continue to see those numbers increase as a result of that over time. Baby boomers are anybody who was born between the years of 1946 and 1964. In addition to that, this population shift is a result of a reduction in childhood mortality and overall just increased life expectancy. In fact, life expectancy at age 65 now is at an all-time high. So we are living longer than we ever have across history, which is exciting if we can live with quality of life, right? So the idea is that we don't want to live those days sick, and we don't want to live those days, unhappy with limited quality of life and healthcare quality of life. So what does this mean? Why is this population shift meaningful for you and I? And I just think as our population ages, our society will need to consider these implications, right? The implications on education, the implications on community and neighborhoods. When I think about neighborhoods, I think about the built environment and how we design neighborhoods. Because if we have more older adults, these neighborhoods need to be age-friendly. We hear that term a lot, but what does that really mean, right? How do we make sure that we are fostering or encouraging people to think about livable communities, communities in which we can remain over the course of the lifespan? In addition, it will have implications for the economy, of course, and ultimately implications for health and healthcare, and all of which are social determinants of health. So none of those variables or factors that I just mentioned are separated in any way from health and health outcomes. Your neighborhood matters. Who you socialize with matters. Where you socialize matters. The economy and your ability to have adequate health care or to engage in healthy behaviors matters. And so this influx or this growth in the population or population shift matters to everyone, even if we realize it or not, right? I tell my students all the time, we teach an introductory to gerontology course. And when I come across the students taking those courses and we talk about why this course is important and why we think that even having this course offered in the core curriculum at Georgia State is important. And I say to them, no matter what you do, no matter what career you choose, we are living in a time where you will have to interact and engage with older adults because that is just what is the result of this shift in the population. And so for me, I think it's important that we think through not only what that means for the population as a whole, but really what does that mean for health and healthcare, and how can we better serve these individuals? So, who are these older adults, right? It's always interesting because when we think about the demographics and how they're shifting, it is true, women do outlive men. So there are going to be more women than men as a result, age 65 and older. This definitely becomes more pronounced as we look at across the trichotomy of old age. We tend to divide this old age experience into 3 levels. So 65 to 74, we consider the young old. 75 to 84 is old, and our oldest old is 85 plus. So as gerontologists, you might hear them speak or reference this trichotomy of aging or aging life experience. This also includes centenarians and super centenarians, which I think is important to include. I have been so excited to just shout this from the rooftop, but I am now the granddaughter of a centenarian. So my grandfather just turned 100 in May of 2019. And so it's been such a blessing to bring that experience to my profession and to what I do. So yeah, it really makes me who I am. So I'm excited. And not only is he 100 years old, he lives alone. Wow. Yeah, I know. Well, he lives in South Carolina, so that's the one caveat. But yes, he lives in a rural area, so he still, as far as his area, he drives his tractor, he drives the truck around. He has a farm, he has cows, animals, chickens. Like, he is still doing his day to day. And so for me, it helps me to understand the importance on promoting health, because when I see him enjoying life at 100 years old, it makes me want to make sure everyone has the opportunity to reach that goal, if that is indeed their goal. So, additionally, a large percentage of men report being married compared to women. Again, that if we are talking about male-female marriages and women outliving men, there's no shock that that's where the statistics lie. As far as divorce, approximately 15%, not 50, 15% of older adults report being divorced or separated. Now, those numbers do not include individuals who report never being married or may have been living with a lifetime with a partner and did not report that as a marital relationship. But what's interesting about that number is, while it seems low, that is a 10% increase over the century. So it was about 5%, and now it's 15% of older adults are reporting being divorced or separated. So it's interesting to see those numbers shift as well. There's a large proportion of community dwelling older adults. So where are they living? Older adults really are living in the community. I know when I first started my journey as a gerontologist, and I was in my, actually even when I was in my master's program, people would ask me, gerontology, what are you going to do with that? And then their first question would be, are you going to work in a nursing home? Now, I have no, issues or dislike or disconcern with working in a nursing home, with being in a skilled nursing facility. In fact, a lot of that information around nursing home residents has informed how I think about addressing health in the community. But gerontology is bigger than that, and that's not where most of the older adults are. Most of the older adults are definitely in the community. So when we think about it as far as numbers, of those 65 to 74, so in that young old, only 1% report living in an institution or in a nursing home, a skilled nursing facility.
Georgia traffic. I'm not used to it yet.
3% of the old, so that is the 75 to 84, and then that number only rises to 9% of the oldest old that live in nursing homes. Now, I'm also careful not to over-exaggerate how low the number is, because we also know long-term care, institution, personal care homes, assisted living facility, the introduction of all of these options have allowed for older adults to not necessarily live in their home, but to receive care in another type of setting. So those low numbers are specifically about skilled nursing facilities and not specific to assisted living facilities or other options. We even know that there are individuals living in their homes who also receive care, that if they weren't receiving certain levels of care at home, that they may be in a nursing home. So community care services that they receive at home, that I know that this group is also familiar with. And then socioeconomic status, geographic distribution. Where are these older people? I'm not really going to go into how they are distributed across the nation, but what I will say is that the older adults are here in Georgia. And so at one point, Georgia was ranked 8th in population growth of older adults. And when we look at that, even with a more narrow lens, the Atlanta region, which is the 10 counties that make up the Atlanta metropolitan area, was driving that growth and moving Georgia up the ladder.
Who was number one?
I don't remember who was number one.
What
Yeah.
state would you remember?
Yes, it's probably because I've looked at the maps before. Florida has always led the pack. So I'm sure, but then because that statistic is based on growth, I'm not sure if they've had the most growth. So that's where I'm careful. So they have the largest percentage, but they have always had the largest percentage. So when we look at some of these other factors, this was specific to growth. And so, yeah. And then socioeconomic status, what is the SES of these individuals and their health status? And really, I just highlight that when we talk about who are these older adults, to bring attention to the fact that we know that older adults is highly likely that they're living on a fixed income. And this is really where we think about the diversity piece, right? What is the educational background? So I started giving you a little information about my grandfather. What I failed to share was that my grandfather, as far as formal education, has no more than a second grade education. Yet he has thrived over, 100 years at this point on this second grade education. But that is important in understanding how we engage with him, right? How we converse with him, why he makes the decisions that he may make. All of these things that actually influence healthcare, specifically when we talk about health promotion and health behaviors. And then health status. So older adults, and I'm actually going to shift our slide a little bit. So we know that as the population ages, that chronic conditions are on the rise. And it was interesting that it was brought up that my work started with a focus on arthritis, and it did. When I was in graduate school, I was really interested in understanding African Americans who were diagnosed with osteoarthritis and how they were managing and how we could mitigate the disparity that we saw between them and their counterparts. And what becomes most interesting about this idea around African Americans and management of arthritis was because, similar to most chronic conditions, African Americans had a high prevalence rate in compared to other groups, but there was some discrepancy about whether or not they were or had the highest prevalence rate, right, compared to whites. But what we saw consistently was they had more pain, more impairment, more fatigue, greater burden from the disease. And so I really became curious as to why that was. If they're not diagnosed more, or if there was a question about, the prevalence rate and looking at different, you can look at different data sets, and one data set may say that African Americans have higher rates and another data set may show something slightly different. And so looking at those numbers, but what was consistent was the burden. What was consistent was the disparity in the outcome of the condition. And so this is really where I became interested in health and healthcare and of those living in the community. So I began to interview older adults who lived in the community who reported having a diagnosis of osteoarthritis. What I quickly found for aging African Americans in my research was that arthritis wasn't necessarily the condition that was most concerning to them. So oftentimes older adults in my study reported that arthritis was a normal part of aging and that the aches and pains associated with it was just a part of the day-to-day. And so I realized that there was something that needed to be done to educate and to help individuals manage and think differently. But what I also realized, which is in line with the data, is that the individuals that I was interviewing, they weren't just diagnosed with arthritis. So it wasn't only that arthritis seemed like a normal part of aging. It was also that I often speculate, I will say. I often speculate that it is possible that because arthritis osteoarthritis. Because osteoarthritis does not or did not in their minds come with the mortality component, that there were other conditions that they thought were worse, right? So if you start telling me I might have to undergo amputation because of my diabetes, if you start telling me about heart attacks and stroke and other conditions that will literally change my cognitive ability, my physical ability, based on whether or not my blood pressure is adequately regulated, I then begin to put an emphasis on those conditions. And if I think that arthritis is just what happens when I become an older adult, I don't see the need or have the drive to think about that in the same way that I may other conditions. Again, this is just based on some of the comments that was presented to me in interviewing many of these older adults. But the other issue to that, or I shouldn't say in addition to understanding that they did not have the same level of, I won't say concern, but they didn't think about arthritis in the same way. What I also found out is that they were diagnosed with arthritis and. So I was initially I started out interviewing individuals who had arthritis. And so they had arthritis and. So it was arthritis and diabetes, arthritis and hypertension, or arthritis and diabetes and hypertension. And the list goes on. So what we see consistently at those age 65 and older, it is almost 40% of individuals in that population have been diagnosed with at least one chronic condition. And as they age, those numbers accelerate. And so about 50% have 2 to 3, and over 15% have 4 chronic conditions. I have interviewed individuals who have reported 7 chronic conditions and are trying to maintain and live in their home in the face, right? How do you, right? And so this is where we can lend our expertise to, at least if, and I've been starting to think differently. I've been starting to think more from a prevention lens, but I do realize that we still have to think about a management lens, because this does exist and this is not going away. It is a burgeoning public health concern, something that we really need to think about. And with the increased numbers in the population shift, these prevalence rates are only going to continue to grow. And so it is on, I won't say the burden or the onus is on healthcare providers, but I will say that healthcare providers, there will need to be a paradigm shift in how we think about providing care to these individuals and who we include in that care. So one of the first things that I think is super exciting about gerontology is that you can't really study gerontology without having an interdisciplinary perspective. It brings a little bit of everybody to the table. Next week, we will be attending our national meeting. The Gerontological Society of America has its annual meeting in Austin beginning next week. And I am telling you, there I will run into anywhere from physical therapists, occupational therapists, biologists, nurses, social workers, everybody coming together to try to figure out how we can best create communities and a society where we embrace this population shift and provide the type of care and support needed, not only to survive, but to thrive even in later life. Did I talk too much? So along with the overall growth of the population, there's also a significant increase in racial ethnic diversity of this population. So racial ethnic minority populations are projected to increase to about over 20 million, making up 28% of the aging population by 2030. It's interesting because I remember when, if I go back to the slides that were looking at the projections, I can remember being in graduate school at the top of the century and thinking that those projections were so far out, right? So they were giving us projections at that point for 2020 and 2030 and 2040 and beyond. And I realized that now I'm 2 months shy. Right? I was like, oh, how did that pop up on us, right? Where are those projections? Is here. Those older adults are here, right? I remember thinking, even with the discussion of 2011 and the first baby boomers, I remember thinking, oh, we still have over a decade. Like, there is still time to address these issues. The time is here and the time is now. And so what's most interesting to me is that not only do we have a shift in the aging population, but we also have a shift in the diversity of the population. And that is important to be considered. When we think about chronic diseases and chronic disease health disparities, we know that the individuals that are disproportionately burdened are those of racial ethnic minority groups. And without attention to that detail, without consideration, we miss the opportunity of meeting the goal that again, I saw the vision of the Occupational Therapists Association. I think about the vision of Healthy People 2020, and I think about my own research agenda and what drives me. And that is not only to mitigate, but to eliminate these health disparities and to have quality health for all. And in order to do that, we have to really consider what is the cultural milieu, right? What is the unique nuances that contribute to how someone of a racial, ethnic, or other diverse group ages. What is the context in which this aging occurs? What is the context in which they experience the disease, right? This is when we start talking beyond the condition and start really thinking about the illness, right? What is the journey that these individuals experience? So really thinking about how a myriad of psychosocial and social cultural factors influence health and healthcare outcomes and their trajectory. So whether that's experience with racism, whether that's low socioeconomic status, whether that's discrimination, whether it's unequal access to goods and services, lack of trust in the healthcare system, just other norms and practices. But these points or these psychosocial factors must be and should be considered. So this is just essentially a conceptual framework that Rebecca has seen probably more times than she'd like to, that shapes how I think about reaching health equity. And when I talk about health equity, I am talking about how do we bring everybody to a point of quality care and quality health, right? So this is not thinking about equal services. This is talking about finding out where people are, what factors influence where they are, and providing the support needed to in order to promote health, positive health, and health care. So what are some of the factors that contribute to the health equity of older adults, particularly explaining what I talk about, or what I mean when I talk about diversity? And that is social class, the individual's gender, where they live, family and social factors, sexual orientation. There is a great deal of work right now focused on older adults who identify with LGBT, and actually thinking about where do they live, how do they find a safe place, where do they have a conversation, how are they received in senior communities. So really understanding the importance of that level of diversity. And my work essentially has a focus on age and how age, on top of all of these variables, influence health equity, specifically looking at race, ethnicity, and culture. Now, I tend to focus my research on race and ethnicity and looking at the influence of that on health behaviors and health outcomes, but I don't ignore that these factors do not exist in silos. So there is a great deal of intersectionality that occurs among each of these factors that make an individual who they are, that helps them make the decisions that they make or don't make, and that contribute toward the outcomes. So this could be anything from genetic components to social factors, ultimately leading to their health outcomes and helping us understand health and healthcare. So I often like to highlight some of the challenges that I see in reaching health equity in an aging population, especially, or I should say, considering the importance of diversity and the factors that I just shared with you on the previous conceptual framework. And in order to reach health equity, we need to consider these areas. services and support that's available, accessible, acceptable, and optimal quality of care. So what do I mean by that? These are very broad categories, but I will give a definition because I think it's important and it will shape a little bit about what I will tell you about my own research studies and what I do in the community. So availability is the sufficient supply and appropriate stock of health workers, right, with the competencies and skills to match the health needs of the population. So making sure that we understand the important needs of older adults, and we have health workers who are equipped and available to service this population. I always challenge, particularly my undergraduate students, who may just, be starting out and trying to figure out gerontology and its importance. And I say, we don't find it shocking to see a pediatrician. We don't find it abnormal to search for a pediatric nurse. We don't have a toddler and we have a pediatric dentist, somebody who specializes in dentistry for youth, for children, right? And so, but it's interesting that we do not put the same emphasis on gerontology and geriatric care. I know I don't have to say this for the sake of the audience, but I do think it's important because oftentimes I know those terms are, I don't want to say confused, but oftentimes maybe used interchangeably or not understood to the great degree, and that is gerontology and geriatric care. And so gerontology is the social science arm of studying aging. And geriatric care or geriatric management or anything that has to do with the base word geriatric is really more so from the medical side. And so I always say it's I compare it to that of psychology and psychiatry. So once I say that, people are like, oh yeah, that makes sense. And so this idea that there is a medical arm and there's a social arm. But what we know about health, and particularly from a public health perspective, is that social piece is very important. So again, availability refers to just having sufficient quantity of functioning public health and healthcare facilities, so whether that's goods and services, as well as programs that are in the context of aging. And this really talks about just making sure services that have a gerontology or gerontological focus are available to individuals. The other piece is accessibility, right? The equitable distribution of these health workers, taking into account demographic composition, rural-urban mix, and underserved areas of the population. So making sure that in the context of right to health, that health facilities, goods, and services are accessible to the individuals who need them most. Acceptability. I think this is very important when we consider sex, language, culture, age, etc., because this is a health workforce with characteristics and ability to treat all patients with dignity, right, regardless of the background, to be able to create trust and promote demand for services that are needed. So this includes, acceptability includes consideration, for example, of whether services are age-friendly, whether they are responsive to an older adult's needs, taking into account the diversity of older people. This is not a homogeneous group, and so oftentimes you'll hear people lump older adults into this, one group. And I would even challenge people to even go beyond thinking of older adults as a heterogeneous group, but also breaking down even some of those levels of diversity and looking at the heterogeneity within the group, right? So not all African American older adults have the same experience. I always talk about, there is a book, it's titled Our Kind of People, and the book is about the Black elite. And it goes into discussions about Black families who have actually been at an elite status or a high socioeconomic status over time for decades. It's interesting that the story of this book and then the story of other books thinking about the African American community oftentimes can be perceived as polar opposites, right? And I say that because oftentimes when we talk about health disparities, we talk about income. And in fact, there's research out there that says, is it really race or is it socioeconomic status, right? What is really the driving factor that leads to these disparities? But again, what we do know that is unique amongst those groups may be some of the cultural experiences and values. So there is some overlap, but there's also some differences that can't be ignored when we treat a group or a person that meets a demographic profile. And lastly, I think a barrier and or facilitator to health equity in an aging population is quality of care and making sure that the health workforce competencies, skills, knowledge, and behavior are according to the professional norms and perceived by the users as quality of care, making sure individuals have this optimal level of care and that it is available to them regardless of a subpopulation or sub-criteria that they may identify with. So before I get to talking about whether or not there is a solution to addressing the issues around health inequities, or can we reach a society where we have healthcare that is available, accessible, and acceptable, and of optimal quality, I'm going to tell you just a little bit more in detail about what I do and how I work with individuals from different aspects of the healthcare field. And so I am interested in behavioral interventions that are delivered in the community. And in those interventions, I am always interested in ensuring that older adults have the tools and the skills that they need in order to successfully manage their chronic condition. Most of this work suggests that when you build the self-efficacy or the confidence of an individual to manage their condition, that they will then in turn be able to take those skills and do the right thing. And I use air quotes because what is the right thing, right? But engage in healthier behaviors, increase communication with their doctors, making sure that they are engaging in exercise and proper nutrition. But understanding how they can achieve that self-efficacy in the face of barriers and challenges. So I interview older adults who have been diagnosed with multiple chronic conditions and assess their desire, their need for not only the utilization of the interventions. So where are the interventions, going back to the previous slide, where are the interventions? So we know that one of the interventions that I work most with in my work is the Chronic Disease Self-Management Education Program. This program is out of Stanford and Kate Lorig. It started with the Arthritis Self-Management Program. It's been around for 3 decades. National Council on Aging also supports the dissemination of this program, and it has shown to decrease negative outcomes associated with the chronic conditions, as well as improve positive health behaviors. And so one of the things that I have done in my work with the Arthritis Self-Management Program and the Chronic Disease Self-Management Program is talk to African Americans in the community about the program. Have you heard of the program? Where, if so, where have you heard of the program? To survey and see if the program is offered in their area, right? To determine if the program is offered in an acceptable manner. So I had somebody say that they wanted to talk about exercise and exercise behaviors, but one of the things that their doctor had prescribed or suggested in a meeting was that they engage in exercising and that maybe swimming or water aerobics would be an option. And again, this was from one of the individuals who had been diagnosed with arthritis. We know that water aerobics is beneficial in that regard because of the reduction of the weight bearing in the exercise, right? But the older adult was terrified.
Of water.
Yeah, she told me she didn't know how to swim. And she said, and when I left, that was the recommendation they gave me. She was like, water aerobics. And I was blown away because I said, wow, we have these packaged interventions, right? And so we have to, I'm a researcher, I know, I get it. There is a component or a piece of fidelity that we can't change the intervention from how the developer intends for it to be delivered. But in the development and evaluation of these programs, we need to pay attention to, again, these unique nuances that might be present that prevent somebody from engaging in optimal quality of care. I know that out of I want to say John Hopkins, and I know that Dr. Gitlin is now at Drexel, but Laura Gitlin has done a lot of work as well as Sarah Zetton on looking at just home modification, things that can be changed for like fall prevention. I know Dr. Gitlin does a lot of work with dementia and dementia caregivers. So thinking about how we not only think about that experience, but the context of where they live, what they understand about the disease. A lot of times when we talk about caregiving or caregiving research, we think about the burden of the caregiver. And how is that burden exacerbated by other social and cultural factors that many healthcare providers may not understand? It's important that we think about these things and think about healthcare from this holistic approach. The other piece of this that I have learned in evaluating existing programs and thinking about how can we make them more culturally sensitive, how can we make them more culturally relevant. I always say, and in any of my published work, you will see that I never make the argument that the behavioral interventions that I work with are not effective. I never make the argument that I don't think they're not working. I do make the argument sometimes that they don't meet or reach the populations most in need. Another piece of this puzzle, I think, is making sure that we use an interdisciplinary lens, right? All of us bring something to the table that can contribute to the solution, right? So understanding, and it's interesting because I always am careful when I say, I want to make sure I say multiple disciplinary. But really thinking about a transdisciplinary, a multidisciplinary, and an interdisciplinary approach to these solutions where we don't ignore social, cultural, and psychological factors that influence health and health outcomes. So in my work, and I want to kind of conclude a little bit at this, when I say conclude a little bit, I want to bring you into the discussion because I don't just want this to be me talking at you, because I think one of the benefits of this is that you're professionals, and when we went around the table, 50% of you have experience working with older adults, right? And so the question is, how do we get to the place where we reach health equity? What is the solution? How do we use these behavioral interventions? How do we get them in the communities that need them, right? How do we collaborate with our community partners? How do we move forward to reach the goal, the mission of the Occupational Therapists Association, the mission of my research, the mission of Healthy People 2020? How do we make sure that this is available, and how do we collaborate to do so? The other thing that stands out from my work is that in speaking with the older adults, oftentimes you will hear them say they have a lack of understanding about behavioral interventions from the healthcare provider, right? So they're not getting this information from their primary care provider. They're not saying, hey, you have X, Y, and Z. Maybe you should look into participating in a 6-week behavioral intervention. Maybe you should look at resources that are out there for fall prevention. Oftentimes, those aren't conversations that are held inside the doctor's office with the PCP, right? So these are the things that all of us from various disciplines and professions can think about, and think about how we can come together to better serve older adults, and to better serve older adults from a diverse perspective. So really thinking not only about aging, but about diversity in aging as we move toward the goal of health equity. And that kind of concludes my talk.